Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. Today, what has long been called assisted suicide and is now called medical aid in dying. Dr. Jeff Kahn, who leads the Berman Institute of Bioethics at Johns Hopkins, and Anna Mastroianni, a legal expert at the Institute, joined Stephanie Desmon to discuss the increased ability in the United States and around the world to help terminally ill patients choose to die on their own terms and the legal and ethical questions surrounding it. Let's listen.
Anna Mastroianni and Jeff Kahn, thanks so much for joining me.
Thank you for having us.
Thank you for having us.
So today, the topic is assisted suicide, and it's something that raises a litany of complex medical and religious concerns. And so I wanted to start, Jeff, what is assisted suicide?
It's a good question, Stephanie, and I think the first thing we'll probably want to talk about is the terminology. People may have heard the term assisted suicide or physician-assisted suicide. The term of art these days, and then one that's most accepted in discussion about policy, as we'll get into, is medical aid in dying. MAiD is the acronym. But over time, it's had various terms applied to it. Voluntary euthanasia, aid in dying, as you said, assisted suicide, and now we're using MAiD. And Anna can, I think, tell us why it's important that we use some terms and not others.
From a legal perspective, because that is my core training, calling it suicide, they've discovered, also triggers criminal laws and insurance consequences that really don't belong in this conversation. So they've been very careful in constructing these laws to distinguish those concepts. For example, if you are classified as having died by suicide, you may have your life insurance denied, even though your death was caused by a terminal illness.
So let's talk about why it's becoming more popular. I know that we heard a lot about it in the 90s. We all remember Dr. Jack Kevorkian, who was spreading the gospel of helping people to die when they wanted to, when they were sick. Why are we seeing more of this today? Why is it okay now when it wasn't okay then?
I think one of the main reasons that we're seeing that today has to do with, first, a very critical distinction between what Jack Kevorkian was doing and what medical aid in dying is. Medical aid in dying has to do with people who have terminal illnesses who are able to self-administer. They can get the prescription from the physician, but they themselves must provide that medication to start the end-of-life process. These are people who are already dying. They probably have at most 6 months to live, or at least that's the prognosis. So that's really important. There were two cases in 1997. One was a Washington case, one was a New York case, and they essentially ruled that there is no constitutional right to medical aid in dying. So there's no right to what was known then as assisted suicide. What that meant was, because there was nothing in the U.S. Constitution that either prohibited or promoted in some way this ability to do this act, that it was going to be up to the states to decide. 1997 was the first, when it all opened up. Then Oregon had a voter initiative. The people voted that they wanted this law. And ever since 1997, we've had some laws in place. Now about 14 jurisdictions in the United States have those laws in place. It's been increasing over time because the public perception has changed. We also have about 30 years worth of data coming out of the initial states that have been doing this highly regulated procedure.
Tell me a little bit more about it. Not everyone is eligible. You have to be terminally ill. In most cases, I understand if your illness is mental, you cannot get permission to do this. Talk me through a little bit of that, please.
It's different in each state in which it has been made legal, so that's an important thing to say. But generally speaking, as Anna noted, the individual has to be determined to be at the end of their life, and typically that's a 6-month prognosis. It usually has to be assessed by independent physicians, more than one, often including a psychological or psychiatric evaluation to assess that the individual is of sound mind. And then, as Anna also mentioned, they need to be able to take the prescription themselves. So you need somebody to prescribe what's a lethal dose, effectively, right? But the person who does the prescribing cannot administer it. And so the individual, him or herself, has to be able to swallow it. So put it into their mouth and swallow it. And so all of those things, be assessed in the proper order. The person then is able to get the prescription. And then, of course, it's up to them about whether they want to actually take the dose. So that's an interesting part of the 30 years of experience that Anna mentioned we now can look back on. So just having been prescribed the dose doesn't mean that a person then goes forward with medical aid in dying. And that in itself is an interesting aspect of the policy evolution here.
I've heard it said that it's not about shortening life, but it's about shortening death. Is that how you would see it, Anna?
Absolutely. That is certainly the rationale for it. And that goes with the conflation with suicide. If you think about suicide suggests that there is preventable self-harm, that somebody is making the choice to live or die. In contrast to this situation, someone is in the dying process. So they are making the difficult decision about when they want to die and controlling the final end.
I also would just add to that it's maybe even in addition to, you're right, shortening the dying process, Stephanie, as you said, it's really shortening the period of suffering or relieving suffering altogether. And I think that's part of what at the base of why people might choose medical aid in dying. They don't want to suffer. None of us want to suffer at the end of our lives. And so it's a measure of control that is offered to people who can then decide whether the suffering they're experiencing is too much or whether the period of their dying is taking too long. And so it shifts that decision-making from someone else, the professionals, to the individual. And that feels like a really important thing to emphasize here.
I see that polls support medical aid in dying for the terminally ill, but I know that it raises a whole host of questions, ethical questions, Jeff. And so I know that disability rights advocates are not pleased with it. The Vatican called it, I think, intrinsically evil. Walk us through that a little bit.
Yeah, you're right to focus on that. And I would add to your list, healthcare professional community also has issues with it from a matter of ethics and professionalism. You're right. It's a question at base about how much control individuals should have over the ends of their lives, which we would call in ethics terms sort of a matter of the respect for their autonomy. Which autonomy should they be able to exercise? And there are different perspectives in answer to that question, different religious perspectives in answer to that question. So some religions view our job as not to decide when our life ends, but rather that's up to God, or it's not ours to decide. And if that's your religious belief that you belong to that kind of religious community, then clearly it becomes more challenging for you to an option of medical aid in dying. I think what's interesting is when we talk about policy, right, at the state and maybe someday at the federal level, it's a question of whether individuals who would not opt for such procedure should be able to prevent it from being available to anybody else. And so it's a kind of how much should individuals be able to decide these things for themselves and how much as a matter of social policy should we try to control it. There's a really important part of this question that you've asked around the professionals involved. So many of our colleagues in the Berman Institute actually feel very strongly that it's not an appropriate role for physicians and nurses to be engaging in helping people to die, that they got into the healing professions for the purpose of preserving life, not helping to end it. They feel very strongly that it's not an appropriate role. Again, it goes to, well, if it's not an appropriate role for you, you don't need to engage in it. Maybe there's a way to conscientiously opt out, but does that mean it shouldn't be available on the part of people who feel that it's acceptable to do and for those patients who want to opt for it? So it's a complicated and complex issue, as you've rightly asked in the question. And I think it goes to the heart of a lot of what we talk about in ethics in medicine and healthcare, which is how much control do individuals have and how should the answer to that question get exercised?
Anna.
I also wanted to say that the disability advocates, clinicians, and the religious groups have really been essential in shaping the safeguards that are in these laws, ensuring that two clinicians have to ensure eligibility, requiring some mental health evaluations so that people are assured that this is being handled appropriately and with dignity and respect for that individual. And that there's no exploitation of vulnerable people. So very important contributions.
Yeah, I think it's a really, really important point. And the concern among the disability rights community is that it's a kind of message to people that your life is not worth living. And one of the concerns around the implementation of medical aid in dying laws is that it sends a kind of message to members of society that, at the end of your life, it's time to move on. You're no longer sort of welcome in our community. And so we don't want that to be the way these laws get carried out or implemented. And as Anna pointed out, the important safeguards that need to be put in place so that that kind of exploitation and concerns about sending messages about who's important and who's not get prevented.
One more thing. I would say that it's one of the things the data are showing is that about a third of the people who get these drugs do not use them. At least the Oregon data are showing that, which I think says a lot about people wanting to have control, but just having the comfort that they have that control or some control seems to be an important consideration in following through with the entire process. People have limited time, but the process itself is not a short one. It's not a quick process.
I wonder if this could be used against vulnerable populations who are seen kind of as a financial burden for their families, for insurers, for the government. I mean, are those kind of concerns in play?
I think that the closest thing to that kind of concern has been coming out of reports in Canada, where some individuals have said they're so desperate because it's a combination of their health and social factors related to their health and not being able to access services and feeling, desperate and without other options, that it'd just be easier and better to die. Of course, that seems wrong in many respects and not what we want these kinds of policies to encourage. And so how do we make sure that those people aren't making decisions because the social safety net is inadequate, to put it more explicitly? And we certainly hope that that's not the reasons that people would use to end their lives.
Anna?
I just want to emphasize that is why there are so many safeguards in place, the multiple requests, the independent physicians or clinicians, the capacity checks. There are felony penalties for coercion. I mean, the long-term data that we have just doesn't show, at least in the United States, any sort of systemic abuse. And we've got, I don't know how many years now, like 30 years. Every MAiD law in the U.S. requires a terminal illness with a 6-month prognosis. And I think that's really, really important. And there's no proposal that I've heard of to expand beyond that, unlike in other countries. So in the U.S., it's limited to terminal illness.
I was going to ask about other countries, so I'm glad that you mentioned Canada, Jeff. In Canada, the laws are looser, right? If you're in chronic pain, if you have mental illness, you can get medical aid in dying. And I'm wondering, from an ethical standpoint, why things are maybe different in other countries than they are here.
I think it's a function of the populations, right? I mean, policies are made in ways that are consistent with the societies in which they're made. And so is it ethically acceptable? There's a sort of independent question about whether we think it's ethically acceptable to help people die because they're in chronic pain or because their social situations are desperate. But if the policy in a country allows that, then it can happen. I think in the Canada case, and it's been reported pretty widely, I think there was a New York Times Sunday magazine story about an individual who sought medical aid in dying in Canada who would not have qualified under the policy requirements in the U.S. as Anna has laid them out. And the sort of what made it a good story was that it was seemingly an outlier, right? It's an example of what we want not to happen. And so to me, I take from that, how do we make sure that those kinds of individuals get what they need so that they don't resort to ending their lives? So it becomes a front page story, not because it's common, but because it's unusual.
And there has been discussion about, not in the United States, but outside, using it for chronic illness, disability, suffering, mental health conditions, children even. And the U.S. model is really unique because it's uniquely restrictive because it's firmly tied to prognosis.
And I'm going to give you the last word. Do you think we're going to see more states adopt these laws?
Yes, I do. I do, because there has been a shift over time in public opinion. About a third of the country is already covered population-wide with access to this approach. And the public opinion polls are showing about 70% in favor of allowing it, allowing people the choice, not forcing it, but allowing people the choice.
Anna Mastroianni, Jeff Kahn, thanks so much for joining me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, Produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacobelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.